Alrighty, well, good evening, everyone. Again, thank you for joining us today for COVID-19 and cancer. My name is Savina Chachav. I'm the program manager at the Cancer Wellness Center. For those of you new to the center, we are a nonprofit organization located in Northbrook, Illinois. We are aimed to improve the emotional and physical well-being of those impacted by cancer, as well as their loved ones and anyone who's bereaved. We provide a variety of free programs and services, which include education programs like the one this evening, and support services and wellness classes. For more information, visit cancerwellness.org. I'm going to submit that in the chat for everyone too. And then, as I mentioned, your audio will be disabled for the program. If you have any questions, for those of you just joining us, please submit them through the chat. And after the program, you will receive our evaluation. We do ask that you take a couple minutes to provide your feedback, and we do really look at it and make suggestions based on it. Without further ado, I would like to welcome Dr. Sigrun Hallmeyer. Dr. Hallmeyer, welcome. I think you should be able to unmute yourself as well and give us a little introduction on your background.
Great. Thanks so much for the introduction, Savina. So yeah, I'm Siggi Hallmeyer. I go by Siggi, although you see my name being Sigrun here in the bottom of the corner here. And if you haven't figured out by now, typically as soon as I introduce myself, people detect my German accent. So this is a German name because I grew up in Berlin, Germany, but I've been in the United States for over 25 years now. And so I practice actually just not very far from you here in Lutheran General Hospital in Park Ridge. I'm a medical oncologist. My practice focus is melanoma and breast cancer. And I actually direct the whole cancer service line at our hospital. And in my capacity, I sit on the cabinet of our hospital. In my capacity, in that, I spearheaded a very large clinical trial in the context of COVID-19 that is involving antibody testing for our medical staff physicians throughout the trajectory of the pandemic. And so in that, I have sort of claimed some fame, I guess, in the whole context of coronavirus and cancer. And so in that, Savina and her team had invited me to speak to you tonight, and I'm super excited for that opportunity because, as you can imagine, with my own busy practice, I field these questions every single day, and it is very much close to my heart to make sure that the information is out there for everybody, because of course, we've all been through a terrible year together, and this has been extremely difficult, especially for patients with cancer. It's hard enough to just be a person and live through the COVID pandemic, but being a patient or a caregiver of somebody who has cancer, it's certainly been very, very difficult. And I have firsthand experience as how hard that has been for many of you. Much of the information that I will be sharing here tonight is actually derived directly from the American Cancer Society. And if you have not heard of them yet, it's definitely a good time to get familiar with them. It's a fabulous resource for all of us professionally, as well as caregivers and as patients. And they actually have an entire section now on COVID-19 and cancer. And so much of my research that I have done in preparation for tonight's meeting actually comes from the resources that are published through the American Cancer Society. Now, as Savina said, we're trying to be interactive, although that's difficult with such a big audience, and especially since we're only in 2D, right? I can't really see any reactions from you and whatnot, and so I'm hoping that by now many of you are familiar with Zoom. You do have the chat function in the bottom of your screen. It says chat, and you just click on that, and you can post a question, and Savina will be so kind. She will be looking through the chat as I'm talking and channel questions to me, that may be a deeper dive into something that we're discussing, or a clarifying question, or maybe even just a comment that would be worth sharing with the group. Okay, so without further ado, Savina, maybe if you want to, however you want to do it, if you want to just read the first question, and then we'll just dive right in.
Sounds good. So the first question, and it's a little, I'm sure everyone's familiar, but can you go over, for maybe those that are not, what is the COVID-19 and what are some of the variants?
Right. Yeah. And it's a funny question because many of us feel, well, doesn't everybody know by now what COVID-19 is? Well, it is actually still very interesting to me to recognize that COVID or coronaviruses per se are not a new invention. This is not a new virus that came out of a laboratory in Wuhan, China, or was maybe created Artificially, coronaviruses have been with us for millions of years. They're known as the common cold virus. We've all been exposed to them throughout our childhood, youth, and now adulthood. But unfortunately, just like many other organisms on this planet, right, these viruses can undergo mutational changes, and in that become more infectious and cause new forms of diseases. And this is how this coronavirus 19 essentially came to surface. It is, again, not an unknown viral form. The organism itself is very well known to us. But in and of itself, this particular virus is a new strain known to have many, many similarities to other coronaviruses that are part of this big common cold family. And that's why the symptoms are in many ways also very common to us, right? The runny nose and the sneezing and the sore throat and the fever, all the things that many of us will experience if we have a common cold. What's unique about this virus is that this can cause a much more severe form of this illness. Obviously, as you know, many unfortunately succumbed of this illness because it is a much more severe respiratory illness. And in that it has that SARS, that severe acute respiratory syndrome acronym to it, because the form of illness that it induces, especially in susceptible patients, is much beyond what we typically see in a common cold situation. So that's just as an introduction. Where did this thing come from? As you've probably also heard just recently in the news, is that the WHO did an investigation because there was a lot of rumors about this maybe having been created in a laboratory in China. And they really have pretty good evidence that this is probably more a species traveling virus, and many believe that it probably came from one of those farms in Asia, specifically in China, where there's exotic animals that are held together, and exotic animals that typically don't share the same sphere that they live in. And so once a virus can travel from one species to another, it is actually a very short leap to then also come to our species, the human species, and that appears to be the more likely route how this came to us.
And that's a great segue. You said this very likely how the virus had spread to humans. Can you talk a little bit about how it spreads humans to humans, and then what can people do to protect themselves?
Yeah, so just like the common cold and many other respiratory illnesses, it requires a vehicle to travel in the air, and that is the droplets, and of course, as we have a lot of respiratory secretions in our nasopharynx, so in the nasal area and your sinuses and in the upper respiratory tract, when we sneeze and when we cough, and even when we speak and when we laugh and when we sing and when we yell, we spew out these micro droplets that are laden with the virus if we're infected. And I'm sure many of you have seen the data that many of us, even just speaking at normal room sound language, like I'm speaking to you right now, the droplets that I'm emerging, from my nasopharynx can travel as much as 6 feet from me. And so if you happen to sit in front of me as I'm speaking to you and I'm projecting these micro droplets, they will land on your face, they will land on your mucous membranes, you touch yourself, etc. And this is how they gain access to you. And that in turn then gives rise to the idea that masks, for instance, are actually extremely useful because they will prevent the traveling of those micro droplets as long as you have at least a 2-layer shield in front of you with either a cloth mask or a medical mask or an N95 or any of those. But that's really the major route of transferring the coronavirus from one person to the other. You have probably also heard about it being possibly transferred via direct contact. So for instance, somebody sneezing onto a surface and it can live on that surface for several minutes, if not sometimes hours, depending on the environment. You touching that surface, then again, you're touching yourself. That is a proven method of how COVID-19 can in fact be transmitted, but appears to be a much less common way of it. The much more frequent type of transmission that we have seen through contact tracing really is where an affected person was in close proximity with other people who then in turn were in close proximity with other people who had unmasked contact in poorly ventilated rooms like restaurants and weddings and those type of things. And that is really our biggest understanding how this virus is spreading from one to the next.
Thank you so much. How does the virus impact patients differently, or does it impact patients differently and caregivers, cancer patients?
Yeah, so that's a great question. And so, we don't really have a lot of data on caregivers per se, or even cancer patients per se. As you probably know, much of the data that has been published, even in the context of vaccination, involved healthy volunteers. And then we have a ton of anecdotal data. Most of it actually initially came from Asia, but now more and more it's coming from Europe and now also from America, in terms of our exposure to this pandemic and how different patient groups have been sort of faring with this, and so there are certain groups that are considered higher risk, and that is the more older people, so people over the age of 65. I typically like to abstain from using the word elderly, as I'm now approaching 50. I don't think one is elderly when you're 65, but essentially what happens as we get older is that our immune system sort of trickles down in its effectiveness. And so older people are definitely more susceptible to infectious diseases in general. And that is also holding true for this virus. As you know, diabetes, heart disease, obesity has also been linked to a adverse outcome with the coronavirus vaccine exposure. And then lastly, what probably is important to know as well is that there is a lot of healthy young people that are completely immunocompetent that may have very poor outcomes for unknown reasons. Some of them may be racially related, maybe even blood group related, those type of things. There's a lot of studies that are happening to further elucidate that. But the take-home message that I would really like to send here is that nobody is protected from a severe outcome of COVID-19. And even if you're a healthy young teenager, you may very well end up in the hospital and on a ventilator. And we have had our share of young, healthy people die in our facility at Lutheran General Hospital without any comorbid conditions, so predisposing medical illnesses, where it is really unclear to us why they had such a severe outcome. So despite the fact that we know of risk groups, there is no group that we have identified that's protected from this virus and should not protect themselves with the appropriate social distancing, masking, washing your hands, all the CDC recommendation that exists.
Thank you so much. I'm actually going to move to the next slide just because I see a lot of questions coming about the vaccine. And so I think if there's any questions further about the virus itself and how it spreads, please feel free to submit them through. Otherwise, we'll move to a little bit more of the testing and then vaccines after. So looking at your second slide, Dr. Hallmeyer, so explain health insurance coverage for testing and care. And then should people still continue getting screened for cancer during the pandemic? I know that is a
big question, right?
Yeah. Big question at the moment.
Yeah. So interestingly, as you can imagine, COVID-19 has been a very expensive illness for the US medical system across the board and in so many different facets. And not to belabor for you, but we had a lot of primary care physicians, for instance, who had to close their offices because they were not able to transition very quickly into a virtual environment with their patients. And they didn't see anybody for like 2 or 3 weeks before they were able to sort of come online. And so large medical systems are really dependent on a continuous revenue stream. So number one, that's been very difficult for hospitals and private practices to sort of maneuver. And then on top of that, obviously the patients that ultimately did get sick with COVID-19 and required medical care and worse yet needed to be admitted to the hospital, were in the intensive care units, those patients typically stay for a long period of time. We have some patients who are still with us 6 months after they were admitted, in the summer of last year, and are still in our hospital facility with COVID-19 related complications. So you can imagine the expense to that. Now, having said all that, the insurances have actually come around and have been, if there is such a thing, quite generous in terms of covering COVID-related testing. They, as you know, of course, also the COVID-19 vaccination, all 3 of them are free and provided to you for free. Now, that does not necessarily mean that any vaccination center that you may go to get your vaccination will give it to you for free, because private practices, etc., they may pass on their cost of administration to you, and that is not illegal, but the actual vaccination itself is actually given to you free of cost. Any care related to COVID-19 infection would be billed to your insurance, just like any other illness that you may have. If you had a pneumonia, you broke your leg on your way to work, or you had a car accident, If you do not have healthcare insurance, as you know, there's many different networks that exist and sort of safety nets, charity care, including many other, local resources. Too much to probably get into detail here. But the bottom line is that COVID-19 is handled very much like any other illness and is covered by the insurance. Now, in regards to screening, yeah, we have seen that even at our facility. Our breast center, for instance, closed for about 4.5 weeks early in 2020 in March and April for any screening procedure. And we have invested a lot of time and sort of reinventing how we do screening mammography to catch up with the patients that have not been screened. And so as of now, as of April 2021, we are actually back with our numbers where we need to be and should have been for routine screening exams for these women who delayed their assessment. But the bottom line is, in fact, I was just on a meeting before coming on here today, that over 1,800 patients within the community of Advocate Aurora did not do their colon cancer screening, for instance, right? And 700 women still up to today are too late on their mammographic screening. And that's just two conditions, right? Colon cancer screening and breast cancer screening. The question is, how many of those patients did we miss that are harboring early stage cancers, which we now will find at a later stage and potentially will, negatively impact their outcome. So if I would have given this talk a year ago, I would have told you it is safe to delay your cancer screening by a few weeks as we're sort of working through a safe administration of cancer screening assessments. It is no longer so. If you are late on your cancer related screening of any type, skin exam, mammogram, your colonoscopy, if you're a smoker, you would qualify for a lung screening, etc. Do not delay. Many of the healthcare facilities are now very good in handling even larger volumes of patients. We've extended hours. Social distancing is maintained everywhere in the waiting rooms. The technology is such that really we're sterilizing everything in between patients. So the medical system is a very safe environment for you to come in. And really at this point, there is no reason to delay any type of routine care. Elective surgeries, elective procedures are safe to do. And in the context of today's question, cancer screening absolutely should no longer be deferred.
Thank you so much. I think that is a very important point that I think is important for people looking to get screening, but also those that need to do follow-ups, even that are post-treatment.
Yeah.
So that's really helpful. Thank you for mentioning it. So as I mentioned, moving on to the vaccine, and this is actually a follow-up questions from people, but do people still need to take precautions if they have the COVID-19 vaccine? And then I'm just going to read a couple of the follow-up, which is someone mentioned there's a friend of hers is teaching and both are vaccinated. Is it okay to get together? How about being around family who've not been vaccinated, but you yourself have been vaccinated?
Yeah. Super good questions, and it is something that even the CDC is grappling with, because ultimately all that is open to study. As you know, the first vaccine was not available until mid-December in this country. So we've had, 3.5 months now to study what happens to this population that's vaccinated. And we don't really understand yet how well a vaccinated patient is protected from transmitting the virus to an unvaccinated person. You remember, even when you get the flu vaccine or any other much more established vaccinations, the protection is never 100%. And even though you don't get sick, and that's ultimately, of course, the idea of being vaccinated, many of us will still have the capability of inhaling the virus, harboring it in our nasopharynx or in our upper pharynx. And then again, as we speak, as we laugh, as we interact with people, we may be transmitting the virus to somebody else. We're not sick from it because our immune system is primed because we're vaccinated. But the person that's across from us at the table who is not vaccinated is at the same risk as if they were around somebody who has not been vaccinated. And so the CDC guidelines still do recommend that we should wear masks when we're in public or in closed environments, 6 foot distancing, hand washing, all that, vaccinated or not, no difference here. Where it becomes a little bit more complex is when the person that you're meeting, like you're describing, the teacher, right? Two of them are vaccinated. Can we get together? And the official recommendation is yes, absolutely. In a group of up to 10 people, if everybody in the group is vaccinated, it is acceptable that they can actually have, gatherings in close quarters without masks, because again, we're believing that these people are well protected with their immune systems having been exposed to the virus. All that comes into play 2 weeks after the second shot, if you had the Pfizer or the Moderna, or 2 weeks after the single vaccination from the Johnson & Johnson vaccine, and so again, there's a little bit of common sense with that as well, because again, none of these vaccines are 100%, so you could still get infected with the virus and potentially even get ill, although again, much less likely that you get severely ill. And if you're in a situation that, yes, I had my vaccine, but now I have a fever, or I have a sore throat, or I can't smell, or whatever it is, you should handle that situation very much as if you have an active COVID-19 infection, and you should abstain from gathering with anybody, stay home, get tested, and essentially still continue with the same safety precautions that we would recommend even if you were not vaccinated.
Can you expand on, if you've gotten vaccinated, can you still get COVID, and how likely is that?
Yeah. So I'm going to owe you that answer as the world is learning that, so as I said, we only have about 3 months of data on vaccinations altogether. As you know, the UK was the first country to even approve the vaccine, in just about a week and a half before we did here in the United States. And as much as research is ramping up amazingly rapidly, and we're producing so much data at a warp speed here, 3 months is just not enough to have sufficient data to give an answer as to how likely it is for patients to be reinfected. I can tell you that I am personally aware of 2 cases that we have at Lutheran General Hospital who had documented vaccinations, who were readmitted subsequently with COVID-19 infections that were so severe that they required hospitalization. They did not expire from it, but nevertheless, that was for us eye-opening, the first 2 patients that had such a fate. So it's certainly not impossible, but again, the likelihood for that to happen is significantly reduced. You all have seen the numbers that have been published from the initial clinical trials by Moderna and by Pfizer, and now by Johnson & Johnson, with an 80+% reduction in moderate to severe illness. Now the reinfection rate will greatly depend on how smart this virus is in getting ahead of us with those new variants, which I'm sure you all have heard about. So far, even the most virulent strains that have been identified in South Africa and in Brazil and in Great Britain, and they all have different names and different numbers, they have not shown yet any detrimental effect with the vaccination efforts. So the vaccines that are currently commercially available globally, and more importantly here in the United States, still seem to be highly effective, even for the new mutant strains. But if you know anything about virology and about biology, it's just one mutation away from that to change. And so many of us in the medical field feel that most likely this vaccination that we are all now candidates for, and coming Monday, it is anybody over the age of 16 here in the state of Illinois that will have access to these vaccines. It's likely not a one-time and over and out type of vaccination. My full anticipation is that we will need some sort of a booster vaccination, and this may have to be an annual thing, very similar to the flu shot.
Can you talk about if, is there a possibility that you might have, or a risk that you might have, that your immune system might over-respond to the vaccine if you're already immunosuppressed?
So that is a fabulous question. Thank you for who raised it. So maybe I want to set a few things straight, because I see that in my own patient population that there's a lot of confusion about what's the role of the immune system. And in that, what is the role of cancer therapies that influence the function of our immune system, right? So our immune system is mainly the composition of our immune system is by our white blood cells, the lymphocytes, the T regulatory cells. There's many different white blood cells that participate in our effective functioning of our immune system. And so when we receive therapy that is intended to suppress our immune system, either by design, so for instance, if somebody has a leukemia or a lymphoma, those are illnesses that affect our white blood cells, and the chemotherapy or the transplant or whatever the treatment we might recommend for a situation like that is obviously targeting those very immunocompetent cells. So in that, patients who have blood disorders that require chemotherapy that decrease the amount of white blood cells are at highest risk of having an injured immune system. And those are ultimately the patients who are considered to be at most risk for developing infectious diseases, including COVID-19. Now, the opposite, right? Many of you have heard about immunotherapy, and that is now a common word anymore. Immunotherapy has become standard of care for many, many malignancies. It started with melanoma, which happens to be my area of expertise, but we're using them now across the board, most importantly, lung cancer, which is still the most common human malignancy, right? Now, immunotherapy, very much unlike chemotherapy, chemotherapy is intended to kill dividing cells. And that's what our bone marrow is doing with our white blood cells. We're constantly making white blood cells. So any chemotherapy really across the board will injure our ability to make white blood cells, and in that will cause injury to our immune system. Immunotherapy is a completely different group of agents. They are intended to induce our immune system to recognize our cancer as a foreign entity and fight it. And so they are actually stimulating many processes within our body to help our immune system to function better. And so in that, we have two concerns when it comes to the administration of these type of vaccines in cancer patients. So let's talk about the cancer patients who we consider to be immunosuppressed, either as a consequence of their underlying illness, leukemia, lymphoma, or much broader as a consequence of therapies that are affecting their immune system, so chemotherapy. Here, the idea really is that we feel very safe in administering those vaccines because the chance that these patients will have an adverse reaction to the vaccine is actually relatively small, because the adverse reaction that we develop against the vaccine is typically an immunologic response, something like anaphylaxis or a rash, right? Like some sort of intolerance to it. And that's driven by your immune system. If your immune system is suppressed because you're in chemotherapy, it's less likely for that to happen. The bigger concern we have for those patients isn't so much safety, but it is efficacy, right? How likely is it that these vaccines will actually have the intended effect in preventing illness in the vaccinated patient? And that is still subject of study. The initial clinical trials that brought these vaccines through the FDA through their emergency use have not included cancer patients on chemotherapy. So we don't have any peer-reviewed clinical trial data. However, we have a ton of anecdotal and well-published data now. And we do understand that patients on chemotherapy are mounting an immune response to the vaccination. It may be a bit less pronounced. So their protection may not be 80, 90%. It may only be 60, 70%. But I tell you, that's a fabulous number, because even that muted response, relatively speaking, is a significant protection against the viral illness compared to no protection at all, meaning no viral vaccination. So we do across the board for all our chemotherapy patients recommend vaccination. I can tell you from my own practice, when I have a patient who I have on chemotherapy, I discuss with them optimal timing, because the suppression of your immune system depends on where you are in your cycle and your chemotherapy. And so in my practice, I recommend the COVID vaccination as close to your chemotherapy as possible. That may be a little bit counterintuitive to you, but the time when I see you to give your chemotherapy is the time when your immune system is at its best. That's when I have room to give you chemotherapy. Typically, the nadir, meaning the low point of your immune system, occurs about 10 days later. That will be the worst time to give you the vaccine, because again, that will be the worst time for your immune system to mount a response. The other fraction, again, is the people on immunotherapy. And that's where we had more concerns that they would have a higher chance of having an adverse reaction to the vaccine. Not so much that they wouldn't mount an immune response, because again, we're not suppressing their immune system, we're stimulating their immune system. Now, again, data is being produced, and I've actually personally reviewed a lot of that data just in the last couple of months. And there was an initial abstract that was presented out of China, where they looked at a group of patients on immunotherapy, where they felt that there was a slightly higher incidence of adverse reactions to the vaccine, like anaphylaxis, severe febrile illness, shaking, chills, that kind of thing. But now that we have vaccinated actually a significant portion of immunotherapy patients here in the United States, that it does not appear to be a negative factor. And so we as cancer specialists have now arrived at a blanket recommendation that any cancer patient should receive vaccination against COVID-19 unless they have contraindications, and they're typically surrounding true allergies against some of the components that are included in the vaccine making process, right? But the cancer diagnosis or the treatment thereof do not represent contraindications, and it's really just a good discussion with your oncologist and your doctor's team to talk about when is the best timing for you to get the vaccine.
We actually have somebody who received the vaccine and noted then getting an antibody test, and they've determined that the test showed there was insufficient number of antibodies. So the assumption is the vaccine failed. Should they get a different vaccine? The person does note having multiple myeloma.
Yeah. So multiple myeloma is a tough illness, right? Because it affects the very cells, the plasma cells in our body that are responsible for producing antibodies, right, against everything. And so most likely this person is on for some form of therapy to mute the response of plasma cells. And in that, you fall into a category of patients where we would anticipate a muted response for the vaccine. We have no data to show that repeat vaccination in a situation like that can overcome that, although intuitively, maybe timing it better in terms of where treatment was administered and how that timing worked and vis-a-vis the vaccination timing, et cetera, can make a difference. But I want to caution one thing. The commercially available antibodies that you can get tested for in a laboratory may not necessarily be the ones that you would be induced to produce by getting the vaccination. And let me be clear of that. There's two different commercially antibodies that you can be tested for. One is against the capsid of the actual virus nucleus. So it's an internal antigen that you will only develop if you have been exposed to the virus itself. You will not have this antibody if you got vaccinated, but you will have it if you had COVID. So it's a true witness of infection. What you get vaccinated against is the so-called spike protein, which is the surface molecule on the virus, which of course makes all the sense in the world. You don't want to vaccinate against an internal protein of the virus, because that means that you get infected with the virus. You need to sort of interact with the virus, break it open, and then develop an antibody against an internal protein. The most effective vaccinations do target proteins that are on the surface of a virus, and that's the case with the spike protein. The spike specific antibodies that are now also commercially available to be tested came on the market only very recently. So I would definitely, the patient that asked that question about the myeloma question, go back to your physician and make sure that you got tested for the spike protein antibody and not for the capsid antibody, because you're not supposed to have capsid antibodies. And that does not mean that your vaccination failed. It just means that you haven't had COVID, which is of course what we want. But again, testing for the right antibody is super important in order to make that differentiation.
Thank you for addressing that. I do want to go back to screening just for one quick second. I did miss this question of COVID and sometimes COVID vaccines giving a false positive on mammograms. Can you talk about that?
Great question. So the COVID vaccination is typically given into the deltoid muscle, so it's the muscle that you use when you raise your shoulder outward, like I'm doing right now. So this is the muscle here, you've seen it on TV millions of times now, right? They squeeze it here a little bit. It's an intramuscular injection. When you get the COVID-19 vaccination from Moderna or from Pfizer, it's an mRNA vaccine. If you get the one from Johnson & Johnson, it's an adenovirus, so it's an actual virus particle. And they're obviously intended to interact with our immune system. Our immune system interacts with foreign entities, including mRNA and including viruses, by sort of digesting the information that has come into the body in the lymph nodes. And it's typically the regional lymph nodes where the injection has happened that can get inflamed. So if you get an injection into your arm, the lymph nodes that are right under here in your underarm area, in the armpit area, can get inflamed, can get enlarged, and can feel uncomfortable. And so what we have learned through experience now is that many women who have had the COVID-19 vaccination, who within the first 6 weeks of this vaccination have come into our breast center for mammograms, have abnormal mammograms. Not because they've developed breast cancer from the shot, but they have swollen lymph nodes as a consequence of the COVID-19 vaccination. And those swollen lymph nodes can be radiographically abnormal for up to 6 weeks. And so we have now made a rule in our center, and I think that's across the board, mostly in the United States now as well, that if you had a COVID-19 vaccination and you're scheduled for just a routine screening mammogram, you should wait at least 6 weeks before you have it, because we've had a lot of women who had unnecessary workup, ultrasounds and even potentially biopsies for these abnormal looking lymph nodes because they would raise suspicion for a breast cancer diagnosis, or worse yet, for somebody who already had breast cancer, this can mimic a recurrence. And so just one additional sentence in that, if you are a breast cancer or a melanoma survivor and you had surgery on one of your underarm areas, you should definitely seek to have your COVID-19 vaccination on the opposite arm. So don't get injected in the arm where you had your surgery. Do the opposite arm. Your lymph nodal clearance is better because you didn't have surgery there. And if you do develop this little bit of lymph nodal swelling, at least you won't have the anxiety that this is a recurrence of your initial malignancy.
Are there other parts of the body they could administer the vaccine other than the arms for people infected?
So it depends on where you get the shot, So if you get the shot at, say, a Walgreens or a mass vaccination site, say, like the United Center or now Wrigley Field, you may run into a little bit more reluctance because these are now medically trained, but not necessarily nurses and physicians who will administer this for you. If you had, let's just say you had a bilateral mastectomy because you had bilateral breast cancer and you had bilateral axillary surgery, right? Or you had melanoma in the center of your body and a sentinel lymph node biopsy tracked to both sides and you needed bilateral surgery. So there's many circumstances where there's just been surgical violation of both areas. I have 2 of those patients in my practice. I had recommended for them to get the shot into the leg, and that was possible to be done at our vaccination site where nurses, essentially can be communicated with, and this was a physician order specific, So if you have such a situation, I would definitely encourage you to speak directly to your physician and have him or her make sure that they talk to the vaccination site that you have an exception to getting the vaccination into the arm. Without that, though, the standard really is to have it being done into the deltoid muscle. And obviously for the vast majority of people, it's safe to do that.
Thank you so much for answering that. If someone does not have side effects after receiving the vaccine, and I know that side effects could be very common and very varied across, does that mean the vaccine did not work?
Wonderful question. And a lot of people have anxiety around that, right? And so I have to say, I'm speaking a little bit out of 2 sides of my mouth, because I will tell the people who tell me, oh my God, Dr. Holmeyer, it was awful. I don't even want to get the second shot. The first shot was so difficult for me. And my pep talk for that will be, look, this is your immune system acting up. That's not a bad thing. Be prepared. Second dose will be harder, and we'll do things sort of supporting them through it. And then the next patient comes in and says, oh my God, I had absolutely nothing. I felt perfectly fine. We, with the large data sets that we now have, and remember, we now have millions of people in this country that are being vaccinated, and there's a large spread of people having absolutely no reaction to people needing to be hospitalized as a consequence of their reaction to it. And you've probably seen the very recent publication from the CDC that showed that our real world data here in the United States is actually better than the initially published data from Pfizer and Moderna, where the effectiveness is actually even higher. And so there's absolutely no reason to believe, if you didn't have a reaction to it, that you won't have a good response to the vaccine. You've just been very fortunate, and I would congratulate you and toast to that. You're lucky that you didn't have to suffer with it, but no concern on my end that you didn't have an adequate response.
Thank you so much. And I do see a request to display the slides, so I will do that in the next couple of minutes. I'm just going to go through the other questions that are here. Dr. Hallmeyer, if you're post-treatment over 5 years, 5 or more, are you still considered immunocompromised
So
for
it
that
really
vaccine?
depends on what your illness was, So let's just say if you had what we call a solid malignancy, colon cancer, lung cancer, breast cancer, pancreatic cancer, rectal cancer, prostate cancer, any of those type of things, your immune system is believed to have returned to a normal level of functioning. What's different is if you are a leukemia, lymphoma patient, or a bone marrow transplant patient. Many of those patients will have undergone very extensive lymphodepleting therapies. So these are chemotherapies and sometimes whole body radiation that really sort of jeopardizes the immune system long term. And so 5 years is not enough. And many patients, even in those scenarios, may never actually return to completely normal immunity. So for my lymphoma patients who have had these forms of therapy, I consider them long-term immunosuppressed. And those patients would need to be handled as if they are active cancer patients.
Thank you so much. Let me see here. Based on anecdotal data you have read, how soon after getting the vaccines may immunotherapy patients have adverse reaction? So this is following up to
It could be immediate, so we've had patients who literally within a half an hour of the vaccination will have a rash, will have hives, as you know, anaphylactic reactions, although rare, are well described with all 3 vaccinations that are on the US market. And the vast majority of those anaphylactic reactions, and maybe just to clarify what that is, anaphylaxis is a form of severe adverse reaction. You have maybe seen this with people who have an allergy to peanuts or an allergy to bee stings. Those are the 2 most common forms of anaphylaxis in this country. And their lip swells up, their throat closes in, and if they don't get emergency help, this is a fatal outcome. An anaphylactic reaction is absolutely life-threatening. They're extremely rare with the vaccines, but they're not unheard of. And that is the very reason, if you have already had your vaccine, you know this, they will not give you the shot and let you go back in your car. You have to sit for 15 minutes to be observed. And if you put on your screening sheet that you have had an severe allergic reaction to anything in your life before, they will observe you for 30 minutes. And that is not arbitrary. Those numbers come out of the data that if people have anaphylactic reactions, they typically occur within the first 15 to 20 minutes after the inoculation of the viral component. And so with immunotherapy, to get back to the question, if you have sort of an underlying immune system adverse reaction potential, where you can develop an anaphylactic reaction, it can truly happen within a few seconds to a few minutes of the vaccination. But I've had patients who had COVID-19 vaccinations a week prior to developing a rash or developing itching, and then even the very significant redness and swelling of the arm, where it was a true reaction to the injection site, and they can happen even 10, 14 days after the injection. So from immediate to 2 weeks later, you can react to it.
So in talking about reactions to the vaccine, are there common concerns right now about developing autoimmune disease a period after getting the vaccine? So the person specifically asks 2+ years, but is there any concern about that yet?
There's concern and we're watching for it. I don't think that we have any data yet to substantiate that concern.
Thank you for answering that. So I do want to, I know we have 15 minutes left, so I'm going to share my screen and share the slides, as that was a request that I got a few times from people.
Yeah, and the slides really just have the questions, because we wanted to have some sort of a guideline here as to what we felt were maybe the more important questions to sort of go through. But I'm actually super happy how interactive this is and how many very good questions have been asked by the audience. So.
Right, and there's a lot of questions coming. So I want to make sure we covered these. So for the first slide, I think that was pretty substantial amount of information covered about what COVID-19 is, how can you get the virus, what are some of the concerns patients have. This is the second slide of questions. Dr. Hallmeyer, any addition to any of these questions? I know a lot was addressed already. And then lastly, we talked about the safety of the vaccine and the availability.
Yeah, I think your audience has mostly very practical questions about their situation. So I'm very happy to just, address whatever questions you may have, and we can go through them fairly quickly so we can address many of them.
Can you talk about actually one of them on here is, does the flu vaccine protect against COVID-19?
Yeah, and the very quick answer is no, it doesn't. But what I want to make sure that we say in that same sentence is you should still get your flu vaccine. Okay, so obviously it's not now. It's not now flu season, and you couldn't even get a flu vaccine if you wanted one right now, I think. But we had a lot of those questions in the fall, where we were dealing with the COVID-19 and didn't have vaccinations yet for that. And so I would tell you that in my own practice, I've had a significant higher number of patients receiving flu vaccinations. And really the argument that I would make there is that you do not want to confuse a respiratory illness with COVID and the influenza infection, So if you can protect yourself from any of those as much as possible, unfortunately, we have so few vaccinations available for respiratory illnesses. Influenza is one of them. And so I strongly recommend to be vaccinated when they become available and when it's flu season again. But that particular vaccination has absolutely zero effectivity against COVID-19.
Thank you so much. I have a specific question that, have you heard of ground glass pulmonary opacities appearing on CT after receiving the COVID-19 vaccine? A person notes that.
Yeah, that can absolutely happen, so ground glass pulmonary opacities, so that's a copy and paste directly out of the CT scan report for tonight's conference here, and so what that essentially means is that there's like a hazy looking infiltrate on the CT scan, and we can see that with pulmonary infections like COVID, like pneumonia, like flu, like any of those, but we can also see them as a consequence of so-called pneumonitis, and pneumonitis is essentially just a fancy word of saying lung inflammation. And again, people who have any type of inflammatory reaction to anything can develop inflammation of their lung tissue as well. Now, I would tell you that that is extremely rare, and that is not a common form of having adverse reaction to the COVID-19 vaccination, but it is certainly a possible form. And if you develop shortness of breath and difficulty breathing, those are typically the symptoms that you have when you have pneumonitis, maybe even some wheezing, a dry cough, that kind of thing. You should not delay. You should come to the emergency department. You may need anti-inflammatory medications like steroids that you have probably heard about, that we use even to treat the COVID-19 infection because what we're treating isn't so much the infection in that situation. We're actually treating your immune system's overreaction to the infection. And in that sense, if you have the vaccine and develop these ground glass opacities, that means that you developed an inflammatory response to this viral antigen that you were vaccinated against, and we need to suppress your immune system.
Thank you for answering that. I do just want to check in with the group here. If there were any questions, I know I displayed the PowerPoint for a little bit. If there's any questions following up to any of those, please feel free to submit them in the chat. Otherwise, we do have just a couple more left. One of them is, and actually this came up a couple times, is it recommended to get the vaccine, Dr. Hallmeyer, if you have a low white blood cell count?
Yeah. So it goes back to the discussion from earlier, right? Low white blood cell count can happen as a consequence of your malignancy itself. So if you have a leukemia or anything else that's affecting your ability to produce white blood cells, or more commonly, it's a consequence of your treatment, right? And it may be very well intended. Again, if we're treating leukemia, we're using medications to decrease your white blood cells. Or if we're treating your breast cancer or your lung cancer or your colon cancer, we're using chemotherapy to kill those cancer cells. And unintended, but of course, absolutely expected consequence of that is that we're also killing your white blood cell count. And that is a temporary effect. So unlike having a low white blood cell count because you have leukemia, and that white blood cell count won't improve until your leukemia is defeated, when you have a white blood cell count that is low as a consequence of chemotherapy, that is a cyclic phenomenon, right? Your white blood cell count will be normal at the time when you're due for your next cycle of chemotherapy, and then it'll drop after you received your chemotherapy. You'll be low, 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 then it rises again, and then you get your next cycle. And so that's why I'm saying, yes, I would not want to give you the vaccination when you're at your low point, because again, I'm counting on those white blood cell counts to form your immune response for the vaccinated virus, right? So I would wait until you're back up to getting your chemotherapy. So I typically say get your COVID vaccine a day or two before, the day off, or a day or two after your chemotherapy. That is where your white blood cell count will be close to normal or completely normal. Then you will drop again as a consequence of chemotherapy into your nadir, and that would not be optimal timing for the vaccine.
Thank you very much. One more, a little bit more personal question here. So the person notes the resulting from long-term Rituxan treatment, I'm not producing B cell antibodies. Many years of monthly treatment to keep the IgG count up. Post-vaccine, I tested negative for nucleocapsid antibody test. Please explain.
Yeah. So you are exactly the person that I exemplified earlier, so rituximab that you have received is a B cell antibody. Okay, so this is a medication that's specifically designed to disable your B lymphocytes from multiplying. And that is, a very, very common monoclonal antibody that we use in many different malignancies, including lymphomas and certain leukemias as well. And, that causes a long-term injury in your body's ability to produce antibodies. And like you are saying, you're getting the IVIG infusions. So what this person is getting, you and I can donate our blood, and the plasma, the liquid portion of the blood, contains these antibodies, and they get mixed into a big container, and then they can be reinfused into patients who do not have ability to produce enough of their own antibodies. That's called IVIG, and it is an immunosupportive therapy for patients who have a defective immune system, either because they were born with it, or they had a disease that developed, or because of treatment, like it is in this case of rituximab. And so in your situation, unfortunately, it is very unlikely that you will mount a very high response to the vaccine, though I would still argue that it's highly likely that you will have some response to it. Now, what you said is that, Savina, I think you said they tested for the antibody, the antigen, and the nucleocapsid.
Tested negative, yep.
Yeah. So again, that nucleocapsid antigen is not the antigen that you will develop as a consequence of, or antibody. It's not the antibody that you will develop as a consequence of vaccination. This nucleocapsid is an internal protein of the virus, and you will only produce that particular antibody if you were exposed to the virus itself. So that is essentially not a meaningful test for you. You should get tested for the spike antigen. SPIKE, spike antigen. Okay, so when you go back to your oncologist and discuss this, and you want to be tested for this particular antigen, it's a different test.
Thank you very much. This question actually was in your slides that we didn't address, but are there vitamins or other over-the-counter supplements to help prevent COVID-19?
So great question. And unfortunately, the internet is a world wide web of lots of information. Much of it is great. Some of it is okay. And some of it is purely wrong, and so the WHO actually has gone out of its way, and on their website, they're debunking some of the information that's been put on the internet that is really false information. Zinc, high-dose vitamin C, those type of things do make sense because they support your immune system. And zinc particularly has been known, you probably know the product Airborne that you can buy at your pharmacy. Those type of things make it hard for viral particles to adhere to your throat. And so zinc lozenges may be the only over-the-counter measure that makes sense. Again, same with high-dose vitamin C. You can't overdose on vitamin C. It's a water-soluble vitamin. So what you don't need, you pee out in your urine. So when you do take that, you notice that your urine is very yellow. So those are sort of minimally risky interventions that may have some effect. Although, again, there's absolutely no peer-reviewed evidence that has any meaningful impact. And anything else that you may see about supplements, turmeric, and whatever else, there's lots and lots of information. Really no basis for that. There's no studied data that prove efficacy or safety in that setting, and so really would not recommend any of those things to be used as a preventative. Now, once you have COVID, those over-the-counter cold remedies can certainly be very helpful. Fever reducers, and Pedialyte for hydration and all that kind of stuff. So treat it like you would any other viral illness, But again, in terms of supplements that have the power to prevent COVID infection, really no data to substantiate that.
Thank you very much. And I know we're getting very close to 7:30 here. This hour flew by, Dr. Hollmeyer.
Yeah.
A couple of people have questions that I think you maybe addressed. One of them is a lymphoma patients post-treatment who have received the vaccine still considered high risk. I think you mentioned that the vaccine is still effective, just at a reduced percentage than the general public. Anything that you need to add to that, or that's pretty?
Yeah, I would not, I would still consider them at higher risk than the average population, despite the fact that they got vaccinated, because again, we don't anticipate that they will have the full effect of the vaccine. So in that, what I would say is sort of level your expectation. You could still get COVID and you could still get sick from it. The chance though that you will actually get so ill that you need to be hospitalized, or worse yet, need to go to an intensive care unit and be connected to a breathing machine, or worse, imagining outcome that you die from it, is significantly reduced. So, but nevertheless, this is not a virus to be joked around with. Dying from it is obviously the most fear that all of us have. But I have now several patients in my practice who've had COVID a number of weeks, a number of months ago, who still have not completely recovered. They're still on oxygen, they're still on walkers, they have neurological deficits, they have difficulty doing any type of exercise tolerance, et cetera, et cetera. So there are long-term consequences to this virus. So dying from it is not the only risk that we're under. And so if you are immunosuppressed, and unfortunately, if you're a cancer patient on therapy, specifically chemotherapy, you're considered that, you should absolutely have your vaccination, but that is unfortunately not a free ticket for mask off and now let's have a party. You should still be very careful.
Thank you so much. So key takeaways for tonight for everyone would be wearing masks still. Dr. Hollmeyer, receiving your screenings. Now we're back to, that's a highly suggested recommendation. Any other key takeaways that you want people to have for tonight before we log off?
Get your vaccine. That is really the biggest headline for me. If you have any concerns that are unique and specific to your situation, do not hesitate to talk to your doctor directly. Believe me, I get probably in a day 10 to 15 COVID-related calls from my patients, and I'm very, very happy to field them. And I have yet to meet a patient where I did not recommend the vaccination. So the vast majority of you on this call tonight, if you haven't had your shot yet, do get registered for it. You know that there's many, many different ways to get it now. I don't think we have a vaccine shortage anymore. And under any circumstance, even on rituximab or with leukemia and whatnot, having the vaccine will provide still more protection than not having it.
Thank you so much, Dr. Hollmeyer, for your time this evening. As a reminder to everybody, we will be sending the recording tonight. And I will be sending an evaluation. Please take a few minutes to give us your feedback. There will be an open question. If you have some additional questions that you didn't feel were addressed tonight, feel free to submit those in the comment box in the evaluation. Thank you so much, Dr. Hollmeyer, and everyone have a wonderful evening.